So I'm going to talk a little bit more about the bidirectional impact of TB and diabetes. And I'll pick up on some of the things that Anil's told us, but I'll also explore the impact at the national level in one of the Pacific Island countries. Okay, so this is just an overview of what I'm going to talk about today. So I will talk about the impact of diabetes on TB. There is less evidence about the impact of TB on diabetes, so I'm not going to present that evidence because some of it is controversial. And of course I'll be using the latest scientific data and evidence and some of what Anil has presented. Secondly, I'm going to describe the response to diabetes and TB in the Pacific, what we've been doing. I've been working in the Pacific for 5 years and mainly working from a programmatic and public health perspective, so I'll focus on that perspective. And I'll include a description of the impact of diabetes on TB at the national level in a country called Kiribati in the Pacific. So Anil has presented these figures, and when you look at them side by side, you can see that there is indeed a very high burden of diabetes globally, and about 12 million people who have been infected with TB. And in our region, I'm just going to draw your attention to our region, which is the Western Pacific region. We have about 1/3 of the world's diabetes and about 1/5 of the world's TB. So I'm just going to focus a few slides now on what is the impact between these two diseases. So one of the key factors about the impact is the incidence on TB disease. So we will see more tuberculosis due to diabetes, and I'll present the population attributable fractions in a couple of slides, which will describe that at the global level and at the national level. These are some of the other impacts that have been described in the literature. So the number and type of TB symptoms has been noted as being different in TB patients with diabetes when compared to TB patients without diabetes. The presentation of TB, so how radiological changes are different in TB patients with diabetes compared to without diabetes. The level of infectiousness. So we know from some of the studies that TB patients with diabetes are more likely to present with smear-positive disease or infectious tuberculosis. The time to sputum and culture conversion. So in TB treatment, after we start TB treatment, we usually monitor patients very closely, and one way in which we do that for people with pulmonary disease is to look at sputum and culture conversion after a couple of months, and that is prolonged in TB patients with diabetes. As Anil described, the TB treatment outcomes are different in TB patients with diabetes and TB patients without diabetes, and certainly there's a marked effect on mortality. There is some evidence about drug-resistant TB being more likely in TB patients with diabetes, although there's conflicting evidence on that at the moment. And a lot of these effects, I think Anil hinted at this, but a lot of these effects on TB are modified by the severity of diabetes and certainly glycemic control. So Anil has talked a bit about these studies, and I just put them up to show you that since 2008 we've had 3 very influential systematic reviews, all coming out of the Harvard School of Public Health, as Anil said. So the first one was looking at diabetes and how it increases the risk of active TB. That was probably one of the landmark studies. The second study, which was also very influential, was the impact of diabetes on TB treatment outcomes. And then thirdly, the impact of bidirectional screening, so screening people with TB for diabetes and vice versa. So they've really been quite influential in our practice. I think we knew in the Pacific for many years that these diseases were associated, but when these systematic reviews came out, we really felt that we could move forward with some activities that had a solid evidence base. So as Anil said, this is the impact of diabetes on TB, sort of highly summarised. And the systematic review from 2008 told us that there was 3 times the risk of progression to active TB if you also had diabetes, that there was 2 to 3 times the risk of remaining sputum or culture positive after commencing TB treatment for people with diabetes. Importantly for us, because we place a lot of emphasis on the outcome of TB treatment, so every patient who starts a course of TB treatment, which lasts for about 6 months, has an outcome recorded, and we have quite sort of strict recording of those outcomes and monitoring. So there's 4 times the risk of relapsing after a standard course of TB treatment, and as Anil said, 5 times the risk of death. And there is a slightly increased risk of developing drug-resistant TB, although more research is needed on that. When looking at the impact of bidirectional screening for TB and diabetes, the systematic review by Gion and colleagues from Harvard showed that if you screen for TB in people with diabetes, the TB prevalence in this population is very high, and it ranges from 2 to 36%, and it increases with the underlying TB incidence in the population and also the severity of diabetes. Conversely, if we screen patients with TB for diabetes, we'll also yield a high prevalence of diabetes in the same order of magnitude from about 2% to 35%. This systematic review also noted that there is insufficient evidence regarding the prevention of TB in people with diabetes, which of course is something that we would like to think about. So this slide, I think, is a really interesting slide and is sort of a take-home message, if you like. So what is the proportion of tuberculosis attributable to diabetes? And there have been a number of studies done on this in the South Texas region and the Mexico region by Associate Professor Restrepo. We know that about a quarter of all TB is attributable to diabetes. In the United States, affiliated Pacific Islands, Dr. Brostrom has demonstrated that about 40% of TB is attributable to diabetes. In our study, which I'll present in a moment, in Kiribati, it's an equatorial Pacific Island nation, we established that a quarter of all TB is attributable to diabetes. In India, it's between 15 and 20%. In the United Kingdom, 11%. And the global estimate is that about 6% of tuberculosis is attributable to diabetes. However, that estimate is a few years old now, and we expect that it's a little bit higher than that. In Australia, a study by Claudia Dobler and colleagues established that 2% of TB in Australia is attributable to diabetes. And what is the future impact? If this is the current impact, what is the future impact? And there has been one study that has done some modelling to look at the future impact. This is by Rizlami and colleagues in Indonesia, and they estimated that in 2030, about 13% of new TB in the 10 countries with the highest burden would be attributable to diabetes, which was a relative increase of 25.5% compared to the year 2010. So we have this impact, we have an association that's established. What do? We know from the literature now that TB and diabetes are associated. We know that diabetes affects certain parameters of TB, so it affects the way patients present, it affects those midterm clinical outcomes, TB treatment outcomes and mortality. Dr. Restrepo will present more on the biological plausibility, but we know that this is biologically plausible, this association. In the Pacific, we have a very high prevalence of both diseases. Diabetes will continue to increase. TB has been increasing since the year 2000. We have some evidence, we have limited policy, but in the meantime, we were seeing patients with TB and diabetes, so we had to respond. So now I'm going to talk very briefly about the response in the Pacific. What did we do, or what have we done over the last few years in the response to the association between TB and diabetes? And firstly, I'll just present some of the data from the Pacific as a whole, and then I'll talk about a study that we did in Kiribati. So this is the region. I just wanted to show you the region. So I'm really talking about the Pacific Islands region, 22 countries and territories, with a collective population of about 10 million people. So a fairly small population when we think about our neighbours. And if we look at the top 10 countries globally, so the highest prevalence of diabetes in adults globally, the top 10 countries are here on this slide, and you can see that 7 of them are in the Pacific Islands region, some of them in very small countries. So 37% in Tokelau, which is a very small country near Samoa, 35% in 2 of the Micronesian countries in the northern Pacific, 29% in the country where I did some of my research in Kiribati, and so on. And so you can see that in the Pacific we have a problem with diabetes. If we look at TB, so this figure presents on the horizontal axis the rate of TB per 100,000 population, and on the vertical axis are the countries in the Pacific. So you can see that rates of TB vary enormously. There are very high rates in the top 5 countries on that slide, and most of the other countries record a rate that's below 50 per 100,000. And if we think about those top 10 countries on the previous slide, so the countries with the highest prevalence of diabetes, you can see that a couple of those countries, so the top line there, Kiribati, Marshall Islands, Tuvalu and Federated States of Micronesia, they have a high prevalence of diabetes in adults and high TB case notification rates. So these countries in particular have a high dual burden of disease. Now, if we take those top 5 bars on the slide, so the countries with a case notification rate of TB greater than 100, and we plot them here, and we look at the prevalence of diabetes in adults, which is in these little glucometers, you can see that there are a couple of countries there who really have very high rates of diabetes in adults, very high prevalence of diabetes in adults, and high rates of TB, so TB case notification rate greater than 100 per 100,000. And those countries in particular are Federated States of Micronesia, Marshall Islands and Kiribati. So I'll just talk a little bit more about the response to this in the Pacific, and we've had a fairly multi-pronged response that has included advocacy, research, policy guidance, some interventions and some monitoring and evaluation that's ongoing. In terms of advocacy, we had a commitment at our last Stop TB meeting. We have a Stop TB meeting every 2 years, and at the last meeting, all of the countries and territories in the region and the partner technical agencies signed a document to say that we understand this association and we commit to provide better care for these patients. For the standards, a policy document, we have this document which I think is in your folders, and Dr. Brostrom will talk a little bit more about this. So we have some standards in the Pacific called the Pacific Standards for the Management of TB and Diabetes. And in terms of research, the countries that you saw on the previous slide that are most affected by tuberculosis and diabetes have been active in doing some research, mainly operational research. So in Kiribati, we've done a case control study to assess the association between TB and diabetes. We've got someone working on some modelling to look at diabetes prevalence. If that increases, how will that affect TB incidence? We've also had some operational research coming out of Marshall Islands, looking at treatment outcomes of diabetic versus non-diabetic patients and the implementation of standards. And in Federated States of Micronesia, they've been doing TB screening among patients with diabetes and looking at the results of that intervention. And in Fiji, they've looked at the prevalence of diabetes in their registered TB patients, and importantly, if those patients are linked up with diabetes care. So I'm just going to present a few results from this Kiribati study. And this is Kiribati, if people aren't familiar. It's a fairly remote place that lies along the equator in the central Pacific Ocean. And TB rates in Kiribati are high, and they've been high for many, many years. The red bar shows the number of TB case notifications, and the green bar shows the TB case notification rate. The government declared TB an emergency in 2006, and you can see there were quite high rates in that year, and they've been high. They've had a slight decline in 2009 and 10, but they're on the way up, and we know that 2012 and 13 they're high again. So Kiribati certainly has a high rate of TB relative to the population. With regards to diabetes, the prevalence of diabetes in adults is about 28-29%, and it will stay that way for some time. The prediction out to 2035 is that it will be about 29%. So Kiribati certainly also has a high prevalence of diabetes in the population. So what we did a very simple case control study where we recruited 275 TB patients and 500 controls from the community who were all screened for TB. So if they had any signs and symptoms of TB, they weren't in the study. We then followed up the 275 TB patients in a nested cohort study, and we looked at the outcomes and compared TB patients with diabetes to TB patients without diabetes. The cases and controls completed a questionnaire and had anthropometric measurements, so height, waist circumference and weight, and everyone received an HbA1c. The controls also received a tuberculin skin test. So as I said, we recruited 275 cases and 499 controls, and we found that about 25% of those 774 people had diabetes. The number of TB patients with diabetes was 101, so the prevalence of diabetes in TB patients was about 37%. Interestingly, and Anil brought this up, but the number of TB patients with known diabetes was about half, 53%, and about 47% or 47 patients were newly diagnosed with diabetes. So I think it shows that there is a lot of undiagnosed diabetes in our communities. In comparison to the controls, we recruited 499 community members, and a lot of them had newly diagnosed diabetes as well, about 65% higher than the TB patients. And this correlates really nicely with some work that's been done in India by Balakrishnan and colleagues in Kerala State, and they screened 552 TB patients for diabetes, and they found that 44% had diabetes, which is very high. And of these, 53% knew they had diabetes and 47% were newly diagnosed. So exactly the same figures you'll see on that slide that we found. We looked at the prevalence of diabetes in cases and controls split up by age group, and we found that for each age group, the prevalence of diabetes was higher in the cases than the controls. And the age and sex-adjusted odds ratio was 2.8, which is very much consistent with the systematic review by Gion and colleagues. We also looked at whether patients with diabetes were more likely to have smear-positive tuberculosis, so an infectious form of pulmonary tuberculosis, and they were slightly more likely to be infectious with a relative risk of 1.2. And finally, we looked at treatment outcomes, and we actually found no difference between TB patients with diabetes and TB patients without diabetes. However, the number in our sample was quite small and wasn't sufficiently powered to detect a difference. We also compared our screening for diabetes with other countries, and this table shows bi-directional screening results for TB and diabetes. And the top few rows, top 4 rows, show the proportion of TB patients with diabetes in the Pacific, and you can see that it ranges from 13% in Fiji to 45% in Marshall Islands. So there's certainly, an association there with many of our TB patients reporting a diagnosis of diabetes. When we screen the other way around, so we look at the proportion of people with diabetes who are diagnosed with TB. In one study in Marshall Islands, they found that 5% of the people in the diabetes clinic had tuberculosis, which is higher than what we would expect in contact tracing. So just to summarise the Kiribati study and what's the impact of diabetes on TB in Kiribati, well, certainly there's an additional burden of TB, and about a quarter of the cases in Kiribati we think are attributable to diabetes. There's an additional burden of smear-positive TB, and that will likely have an impact on ongoing TB transmission in the community. Treatment outcomes were not affected, however we did have a small sample, and we know from the systematic review that TB treatment outcomes are affected by diabetes. And I think importantly there was a lot of undiagnosed diabetes in the community and in TB patients. So just to summarise about the global impact, I think we now know from the literature that there is an additional burden of TB which is attributable directly to diabetes. It's estimated at 6% at the global level. It's up to 40% at the national level. We know that TB patients with diabetes are more likely to present with infectious tuberculosis, and they're more likely to remain infectious despite TB treatment that is well proven as being effective. We also know that poorer TB treatment outcomes will be recorded in TB patients with diabetes, including high death rates. And from the data on bidirectional screening, we know that it's a reasonably effective public health intervention, and that diabetes and TB detected through bidirectional screening will result in additional cases of both, and the rate depends on the setting. So I'm just going to finish with a couple of quotes from the TB literature, and I guess I just wanted to show people what the TB community is thinking about TB and diabetes. So I won't read this whole one out, but this one says, to succeed in reaching the MDGs, to succeed in reaching the target, it's important to focus in resource-poor countries not only on HIV/AIDS, but also on the burgeoning epidemic of diabetes as a significant epidemiological risk factor. The link between TB and diabetes has been well established. What we now need is good quality implementation research to screen for, care for, and monitor this dual burden of disease. With a global diabetes epidemic that is escalating rapidly, the prevention and control of diabetes is likely to be an equally important intervention in controlling the diabetes and TB epidemic. And finally, I won't read this all out, but so the current diabetes epidemic may lead to a resurgence of TB in endemic regions, especially in urban areas. This potentially carries a risk of global spread with serious implications for TB control and the achievement of the MDGs. So I'd just like to finish there. Thank you.
Thank you. Thank you, Kerri, for listening to what we mentioned. Now